Okay, so good morning from here, everybody. My name is Bolaji Yoade. I'm a research extern at Interfaith Medical Center in Brooklyn, New York, and also an MPH candidate at Regis College, Massachusetts. So today I'll be presenting on a research paper that was published December 2020. The work was actually completed with some resident doctors at Interfaith Medical Center and with the attending physician, Dr. Yoade Jijolayemi. The title of the presentation is on the use of a modified kubler-ross model of grief to treat bereavement in schizophrenia. The background. Elizabeth Kubler-Ross proposed the 5 stages of grief, describing the experience people may have after a loss. The experiences could be denial, anger, bargaining, depression, and acceptance. And those are the tools to help us frame and identify what people may be experiencing at the time of grief. But there is limited application of therapeutic approaches bereavement in patients with mental illness. Models and therapeutic approaches to bereavement are focused on patients without mental illness. A question arises as to how the models of bereavement may be modified in schizophrenia and what are the possible adjustments in bereavement counseling for those with schizophrenia. So in this paper, we describe the case of a 50-year-old African-American male with a history of schizophrenia, living with the decomposing body of his dead mother for several days. We utilized modified kubler-ross and bereavement counseling models in this patient with a resolution of the psychotic denial phase of his loss. The case summary. The patient was a 50-year-old African-American male with a past psychiatric history of schizophrenia, found living with the decomposing body of her mother for several days, and at presentation came in mostly with negative symptoms of schizophrenia. The score was 32 on the positive scale and 39 the negative scale. Monterey Cognitive Assessment Test revealed a score of 26 out of 30. So these are some of the symptoms the patient presented with. Positive symptoms include hallucinations. Patient was having auditory hallucinations of mother and visual hallucinations of a red phone connecting him to his mother. Patient had disorganized thinking, incoherent speech, tangentiality, delusions, fixed belief that he is constantly in communication with his living mother with a red phone that rings overnight. For the negative symptoms / cognitive symptoms of the patient, there was affective flattening, limited range of expressed emotion, both, one second, I'm trying to get it off my screen. Okay. All right. So limited range of expressed emotion, both at home when found with mother and during the hospitalization. There was also alogia, poverty of speech, which was demonstrated during hospitalization. The patient was socially withdrawn. There was limited social interaction at home and during the hospitalization, also demonstrated low energy during the hospitalization. There was cognitive distortions in understanding the definitions and irreversibility of death. The patient bereavement at that time was best categorized to be in the denial stage, which was complicated with delusions and auditory hallucinations of a living mother. So at that time, we resumed the home medications of clozapine, starting at a dose of 50 milligram and optimizing to 600 milligram over a period of 2 weeks. Cognitive behavioral therapy, CBT, divided into 20 sessions, was scheduled for the course of his hospitalization. So this CBT was actually aimed at moving the patient through the stages of the grief. So the CBT was geared towards establishing the moral stage and regression of the patient personality. CBT was further geared towards assessing the patient's defense mechanisms and observing his response to the news that his mother would not be coming to see him in the hospital. During the 4 week of admission, the overall effect that the combined pharmacological and CBT therapy had on the patient's understanding of his circumstances, as well as his level of processing of grief within the accepted bereavement model, was examined. So looking at our patient, the kubler-ross model was used on our patient, but given the psychiatric mental condition of the individual, the emotional processing and linearity of thought are different compared to that of a patient without a mental health history. There's the predominance of the denial stage and acceptance stage, with the anger and depression stage being limited by negative symptoms, and the bargaining stage was limited by thought disorder and delusional beliefs that the patient had. So the most apparent progression of the patient was from denial with perceptual disturbances and delusions to bargaining with magical thinking and thought disorder, and finally to acceptance with resolution of denial and psychotic symptoms. So looking at the differences between the kubler-ross model of bereavement and the modified kubler-ross model that we used on our patient. So for the kubler-ross model, we already said we have the denial, the anger, bargaining, depression, and acceptance. But for patients with psychiatric disorders, maybe schizophrenia, all these stages may not be pronounced in the patient due to some distortions in thoughts and in the thought process of the patient. So looking at these differences for the kubler-ross model, the denial, that is usually the first reaction. And in this stage, individuals believe the death is somehow mistaken and cling to a false preferable reality. But in a patient with schizophrenia, denial is usually with perceptual disturbances. There is denial. However, the degree of denial is modified by the presence of hallucinations and delusions that is congruent with the denial. Also, auditory hallucinations of the dead, visual hallucinations of objects associated with the dead may be present and be severe enough to need treatment, in addition to helping the patient move through the denial. So to the second stage, which is the anger for kubler-ross model, when the individual recognizes that denial cannot continue, they become frustrated and express anger towards the situation. But for the modified kubler-ross, the anger could be blunted by negative symptoms. Patient may have negative symptoms, including blunting of affect and apathy, that prevent the expression of the frustration. Therefore, this stage may not be readily apparent in patients with schizophrenia. The third stage of kubler-ross, which is bargaining, the patient attempts to postpone their sadness by imagining what-if scenarios. But then in the modified kubler-ross model, bargaining is limited by thought disorder and delusional beliefs. The presence of disorganization of thought may make the creation of clear what-if scenarios difficult in patients with schizophrenia. Therefore, this state may not be present. If present, the what-if scenarios may involve scenarios with persecutory content or scenarios that demonstrate magical thinking in patients who exhibit delusional thoughts. Moving on to the first stage, of the kubler-ross model, which is depression. The individual despairs at the recognition of the situation. In this state, the individual may become silent, refuse visitors, and spend much of the time mournful and sullen. But for the modified kubler-ross, the depression stage in the patient with schizophrenia, the presence of negative symptoms such as apathy and affective blunting make this stage not apparent or not existing in patients with schizophrenia. The acceptance stage, which is the final stage of kubler-ross model, the individuals embrace the tragic event and a more stable condition of emotions. So for the modified version, this is the stage in which patients with schizophrenia, they embrace the tragic event, giving affective blunting, limiting emotional expression. Emotional stability may not be a sign of this stage. A sign of acceptance will be resolution of the denier and accompanying psychotic symptoms, such as perceptual hallucinations and delusions. So in conclusion, a modified model of kubler-ross that takes into account abnormal thought content and processes in schizophrenia may be utilized to model and treat bereavement in schizophrenia patients. More studies need done on the possible utilization of our modified model and therapeutic approach in the treatment of schizophrenia and bereavement. And here are some of the references that was utilized in writing up this paper. And thank you so much for listening.